Hello, everyone. I'm Dr. Jennifer V. Brown, your stroke specialist. And today we're going to talk about how to strengthen the trunk after a stroke. We often think that only the arm and the leg is weak after a stroke, but that's if you have damage to the lateral cortical spinal tract. You can have damage to the anterior cortical spinal tract that affects your proximal muscles here at the shoulder and at the pelvis, and what we call your axial muscles, muscles of your trunk. All right. And so that often creates a problem because you may have arm movement, but not good trunk movement. A second lesion in the pons may cause damage to your lateral vestibulospinal tract. So the reason why your trunk stays upright and strong is because it's connected to the vestibular system in your ear, and the vestibular nuclei in the base of your pons down in your brain stem has tracts connected to it to react to the position of your head. So you want to right your trunk. Excuse me. So when you're laying down and you see something, you right your head. But if you hear something, you want to right your trunk and turn your head towards it. So that trunk movement is dictated by the lateral vestibulospinal tract. Last, we have the medial and lateral reticulospinal tract. These tracts originate lower in the brainstem. The green one is the medial or pontine reticulospinal tract. It helps to facilitate extension in the trunk. It works with the lateral vestibulospinal tract. And then a little lower in the brainstem, called the medulla, the blue tract is the lateral or medullary reticulospinal tract, and it facilitates flexion of the trunk. At certain times, you need flexion and extension, but as you move towards the top of your brain, we want to be more upright. So flexion is at the bottom, at the medulla. Then you go to the pons where you have extension. And all of this allows us to be intentional about uprightness so that we can interact with our world. So again, damage to three tracts: the anterior cortical spinal tract, the lateral vestibulospinal tract, and damage to the medial and lateral reticulospinal tract all impact trunk function. So, what happens if you have damage to some of these tracts? Well, it depends on the location. So for the anterior cortical spinal tract, you may have weakness at your trunk here, proximal, and at the pelvis, and then along the spine muscles. Okay. But you can sit independently. You can walk, but you're going to be dependent, but it's not functional because you have to control your center of mass, all right, over your base of support. And if you have weakness in your trunk, you can't keep your trunk over your right leg and be in stance phase and then shift it to the left. So I've seen clients like this. They can sit in a chair independently and they use something, to keep them upright. But as long as they're leaning backwards like this, they can sit. Now, if you have a lesion in your pons and you significantly affect your lateral vestibulospinal tract and the pontine or medial reticulospinal tract, it's called locked-in syndrome, and you are pretty much dependent for all functional movement. All right. And these clients can move their eyes because of the location of the cranial nerves. For the most part, they are dependent for everything. I've seen people use a joystick with their mouth and communicate with their screen. Um, there was a famous book put out about the butterfly. I can't remember its name, but these people can lead full lives. They just have no motor movement. Okay. So let's look at some treatment ideas for what we can do. So start off and sit. Now remember, the arm can function distally. It's the trunk that's weak. So sometimes I have the heavy side arm secured to a post and just holding this. And then I, as the therapist, come and move the post, and the force has to go through the arm to the trunk. And then that's an isometric holding pattern in resistance. But then you can reach back from the post, grab the post at different heights, and that works the trunk. So now you're moving the body on the arm. Then that was a shortened lever arm, as you see in the pictures with the elbow bent. And then I move the bar further away so that the arm is straight. And so they have to reach back, reach up to the post at different heights. And then I apply resistance to that post, maybe with the hand behind them in weight bearing. And it really engages the trunk. Sometimes the opposite hand is up in the air while they're holding the post with their elbows straight. And that really works the trunk. There are a lot of things you can do: PNF patterns, alternating isometrics, hold, relax, active movement, rhythmic stabilization. But sometimes I like to engage the arm in functional position. So people have to grab things, pull it back, elbows bent, elbows straight. In this photo, people may not be able to get their arm up in the air because of the weakness in the proximal shoulder girdle. So I have them hold on to a chair and they're reaching back to the cones. Maybe I have the cones in an arc from 0 to 90 degrees, and they have to go 0, 30, 45, 90 behind them. All right. Sometimes I tie TheraBand to that chair and they're taking the TheraBand to the hand, going to the cones at each side. And again, you can do PNF patterns in this position in sitting. Um, what about working the lower pelvis um, um, through the thigh? I tie TheraBand to the distal part of that thigh at the knee to the chair arm. And as I reach back, that leg has to go towards the side that I'm reaching. I have that thigh move up in the air against the resistance of the band. So there are things you can do to work the proximal pelvis as well as the arm by rotating. I love PVC piping. And remember, if it's a true anterior cortical spinal tract lesion, your hand should be able to function so they can grip. If they cannot grip, add duct tape, reverse it, and it's sticky, they can hold on. But when you take that PVC piping and pull back, and then pull forward, you're activating the core. You may not be able to get up that high. Maybe you just be able to push out. But having the TheraBand around the trunk engages the trunk. All right. And whether that PVC piping has a 90-degree joint or 45-degree joint, that changes the work of the core too. You don't always have to be sitting or standing to work the core. I love having a person lay down on their side. The hemi leg is the one that has the TheraBand on and it's bent. But look what happens to the core when the stronger leg is lifted. As you can see, it activates. Now, if you wanted to activate more, apply resistance at the distal thigh or at the ankle, or put an ankle weight, and make sure that the foot stays horizontal during the movement. Back to sitting. Again, I love the use of TheraBand. Look at this. So he comes forward, he has to hold it, and then he rotates through the trunk. All right, and we're moving slow and going back. Again, different ways to work the trunk. Notice we were working the upper part of the trunk. Now let's work the lower part of the trunk. So the TheraBand is in a different place, and they're having to rotate the lower pelvis as if you're doing unilateral scooting, but he's doing more of the rotation part. If you had to weight shift to one side, lift up that hip and then bring it forward, rotate it forward, rest down on it, and then you weight shift to the other side and do the same thing. It really helps if the trunk can move segmentally. Think of it in 4 quarters: for right, upper left, lower right. Can you move each of those quarters independently with your internal obliques, external obliques, and using the rectus abdominis and the transverse abdominis as stabilizers. And remember, when you turn on your transverse abdominis, the big fan muscle like this that connects the lower abdomen sides here together, you are activating your multifidi, those small triangular muscles of your spine in the lumbar region. So it's good to do those exercises to activate internal obliques, external obliques, transverse abdominis, rectus abdominis. These are some clinical questions to ask. Is there compensation at the trunk to lift a weak arm or leg? And if there's compensation, then your anterior cortical spinal tract may not be the problem. It's the lateral cortical spinal tract that's the problem. Is there distal arm and leg movement? Hand, elbow, knee, foot, ankle. If there's distal movement and then you can't control the trunk, it's an anterior cortical spinal tract problem. And then is there segmental movement of the trunk as I just discussed? Are they log rolling in bed? Are they segmentally rolling? Are they moving their shoulders and then their pelvis, or move their pelvis first and then their shoulders? Are they unilateral scooting? Are they bilateral scooting, lifting up and moving the whole trunk at one time? Look at how the trunk is moving. Alrighty. Is there shortness on one side and elongating on the other? That may be because their arms are short and they're pushing down to the surface in order to use it to come up on the stronger side because the hemi leg and the hemi arm is weak. Okay, so those are some things to consider. Remember, I am your trusted source for all things ankle foot orthoses and stroke neurorehabilitation. And don't forget about the references. You have to use the evidence to improve your clinical practice and the outcomes for the patients and apply them appropriately, because just because the evidence says so doesn't mean that it'll do the thing or fix the it in terms of stroke impairment for your client. So make sure you apply the evidence appropriately. Thank you for watching this video. Don't forget, like, share, subscribe. See you next time. Bye.